Started. Good evening, everyone, and welcome to our fertility preservation webinar. We're very glad that you've chosen to spend your evening with us. Tonight, we're honored to have Dr. Li-Wing Li here to guide us through the fertility preservation process at Pacific Fertility Center. This is a great opportunity to gain valuable insight and better understand what to expect on your individual fertility journey. Throughout the presentation, feel free to submit your questions at any time using the chat or Q&A feature. At the end of the presentation, we'll address these questions, so feel free to just send those over whenever you have a moment or whenever they come to mind. As a thank you for joining us tonight, we're offering a $99 new patient assessment, which includes the initial ultrasound with your physician, and it also includes a follow-up ultrasound as well. It's a great first step towards understanding your fertility options. So without further ado, let's get started, and please join me in welcoming Dr. Li.
Hello, thank you, Stephen. Welcome everyone, and I'm appreciative of you showing up tonight for the getting a little bit of information on egg freezing. I'm one of the 4 physicians at Pacific Fertility Center, and I have been here for about, this is my 14th, or actually going on to be my 15th year. So definitely had a tenure here. I love the practice, I love the Bay Area, and I'm very honored to be able to work with, my mentor, Dr. Ryan, and also my colleagues, Dr. Agar and Dr. Strug. I came to PFC, like I said, 14 years ago, and after a bicoastal, training, I did my medical school at Harvard and came out to UCSF to do my OBGYN residency. And that's when I fell in love with the Bay Area. To be a reproductive endocrinologist, you have to do a clinical fellowship in reproductive endocrinology and infertility. So I did that in New York at Columbia. And after my training, I decided that, we definitely want to build our roots here in the Bay Area. So we came back here, and I've been working at PFC ever since. So tonight, we're just gonna go through some basic kind of an educational information session. And the topic is focused on fertility preservation. We'll go through a little bit of, diagnostic modalities, predictors of fertility. We'll go through the egg freezing process and a little bit of success rates. And like Stephen says, please, submit your questions to a Q&A, and I can answer them towards the end. So, why freeze eggs or embryos? I think at this point, definitely in the Bay Area, metropolitan area, most of women, most of us are very well informed on our fertility, and and people being very proactive in protecting our fertility and kind of getting ahead of it. But really, the underlying reason why freezing eggs and embryos was a concept that really is worth investigating, and now that for patients to really kind of consider pursuing is the fundamental fact that our ovaries decrease in function, in our ability to conceive as women get older. So here is the sentinel study in our field that was done decades ago, that links women's fertility with age. So you can see that each line in this graph reflects a fertility rate of a population of people, and it's listed, the populations listed in here, and you can see that they are of different ethnicity, different time in history, different geographical location, and these populations of people have good documentation of fertility, because at that time, especially these are groups that didn't do a lot of outside of kind of group marriage. They didn't travel far away. There was good record keeping. So they were able to track fertility. It's obviously a retrospective data looking through historical text to figure out the fertility. And really the fertility rates are just calculated by simply saying how many how many kids are in each household, and it's plotted against the age of the woman at the time that they are married. Right. And you can note so that some some of the time duration of this study are before contraception, before modern medicine. So there's really it's pure fertility without being influenced by technology, abortion availabilities and contraception. So what is striking to me always is that these lines are so matched on, to each other. They're right on top of each other. And that reflects a very consistent underlying, biological phenomena, which is that our fertility is highest when women are in their 20s. And by early 30s, we see a kind of a transition from and where the slope of the curve starts to become a little more steep, and the rates of fertility drops pretty rapidly as we get older into our early 40s, to the point by kind of mid 40s it becomes incredibly difficult to conceive naturally. And on a kind of a molecular level, on our cellular level, what happens is that women are born with all the eggs that we're ever going to use in our lifetime. So we estimate that for most of us, we're born with about 1 million eggs at birth. And these are immature eggs that are in very early stages of development, and they're microscopic. And every day throughout our life, even and this is independent of puberty or any hormonal contraception, etc. Every day, some eggs will die because they have gone through their life cycle and they undergo attrition and gets absorbed by the body. So it's estimated that by age 13, puberty, already 2/3 of our eggs are already gone. And by age 40, it's estimated essentially 99% of the egg supply has been depleted. So what that, in addition to decreasing egg count, it's not in the slide, but we also see a decrease in the quality of the eggs. So it's not just that we're losing eggs, but the eggs that remain in our ovaries are of lower quality over time. And when I say quality, I'm mostly referring to, can the egg complete this process called meiosis, being able to split its chromosomes in half and be able to pass on half of our DNA to the next generation. So that is a very critical aspect of egg quality. And it turns out as we get older, more and more of our eggs make a mistake in the meiosis process. So a combination of decreasing egg count and worsening egg quality is what is underlying the overall decreasing chance of pregnancy as women get older. Now, how do we know what our fertility is right now, and how do we know what it will be in 2 years, 3 years, 5 years, or 10 years, right? So there are some tools that we can use to predict what our current fertility is. Now, first of all, the egg quality, like I was talking about, the ability of the eggs to undergo meiosis correctly. Unfortunately, we don't have very good tests to test quality. So it is best predicted by age. There are very good ways to assess how many eggs we have, the quantity of eggs. One of the simple tests to look at egg quantity is AMH. It's a blood test, stands for anti-Mullerian hormone. And this hormone is secreted by immature eggs in our ovaries. And the level in the blood reflects overall the quantity of eggs that are in this developmental stage. And then AFC stands for antral follicle count, which are small immature follicles that are visible on ultrasound that we have at the beginning of each cycle. And this group of follicles at this developmental stage, it's a surrogate marker for the total number of eggs we have in reserve. So here's a couple of ultrasound images of antral follicle count, antral follicles. So here on the left, here's an ovary, right? And these black openings or black dots are antral follicles. So each one is an antral follicle. So this ovary has, in fact, quite a few follicles if you count them. And this would reflect a patient with good egg count and therefore good ovarian reserve. Here is a picture of an ovary with only, let's see, really one visible antral follicle, one big follicle. So this would be considered someone with very low egg count. So when you come in initially for your evaluation, we will be doing a vaginal ultrasound, and one of the purposes for vaginal ultrasound is to count the antral follicles and assess your egg count. And anti-mullerian hormone, AMH, the blood test, is, like I said, it's secreted, it's produced by the antral follicles. And the level in the blood is just reflects the overall size of the antral follicles in our body or in our cycle. And it turns out it matches pretty well the number over age, it matches the fertility curve plotted against age. And we see that, it's actually a very nice blood test because it's not, you can do that test any time of the cycle. You don't have to wait for the second day of your period, like FSH test must be done. It's also, for the most part, not significantly affected by birth control or other hormonal contraception, although some patients can be an exception to that. So we usually do an egg count with ultrasound as well as getting a blood test to look at the AMH level, and then compare that to age-matched average numbers to give a patient a sense of where they're at in terms of their fertility. So obviously the fertility preservation, I mean, like getting assessed for your fertility is looking at your egg count, your AMH. People don't really think about, overall how we can protect our own fertility, but there are ways to do that in addition to just freezing your eggs. I think one of the most important strategy is something we learned in sex ed in high school. Really, preventing sexually transmitted infections is one of the most important ways to protect our fertility. And obviously, nowadays, in terms of genetic testing, we do have a lot of options for patients to do genetic testing. So it's also a way for you to kind of gauge your reproductive risk by knowing your family history, and also do the blood test for expanded carrier screening to know your genetic risk, so that you can plan for treatments, or in terms of egg freezing, if you have some genetic risk, then you can potentially freeze additional eggs. So all of these are adjuncts to the concept of egg freezing. So the actual process itself starts with understanding what is the process of what is the chemical reaction for freezing eggs. So what we do is something called vitrification. So vitrification is a very, very rapid cooling. It takes matter from basically liquid state all the way to bypass the ice crystallization all the way to solid state. And this process is very good for eggs and embryo freezing, because by reducing as much ice crystal formation, it protects the membrane of the cells to allow them to basically withstand this rapid temperature change. And basically keep viability after they're warmed. So prior to vitrification became widely used, we used slow freezing. And slow freezing embryos probably was working pretty well, but for eggs, it just didn't work nearly as well because, again, because of ice crystallization, we were losing, over 50% of the eggs with the slow freezing process. But with the vitrification, we found that, embryo survival is essentially 99%. With the egg survival, we're probably reaching somewhere around 85 to 90%. So that it's a very reliable and proven technology to preserve eggs. The patient goes through a few steps, first of all, to prepare themselves for the actual egg freezing. So first they have to do blood test to, the AMH as well as sexually transmitted infection testing and blood count to make sure that they're not anemic. Then they work with our team, financial team and the clinical coordinator team, the nursing team to learn to go over the consents, learn how to do injections, and also kind of mapping out the calendar. Then with all of that knowledge, and then they come for their actual treatment. The treatment starts typically at the beginning of a cycle, so someone usually on the second day of their period. But if the patient's on birth control or hormonal contraception and they don't have regular periods, it's okay. We basically will plan a time where their ovaries are at rest and they can then start injections. So we do a baseline ultrasound to make sure that ovaries are quiet. Then they start fertility injections, hormones that stimulate follicles to grow. And typically it takes about 10 to 14 days of daily injections. And during that time, we will continue to do ultrasounds and blood tests to monitor the growth of the follicles. And at the end of that 2-week period, we'll then do an egg retrieval procedure to get the eggs out. So, like I said, the fertility medication are essentially hormones. The purpose are to grow multiple eggs. So because I had already shown you that we have antral follicles in our ovaries. These are immature follicles that are available in our ovaries every cycle. Naturally, without medication and without contraception, we only will grow 1 egg per month, per cycle. But with the fertility medication, with FSH, the goal is to stimulate all of the antral follicles to grow. So if our antral follicle count is 10, so hopefully we can get 10 eggs. If it's 20, we can get 20 eggs. And for some patients, if they have a low egg count, 4 or 5, they maybe only get 4 or 5 eggs, and they might need multiple cycles to get more, to collectively harvest more eggs. But we cannot get multiple eggs without taking that FSH or fertility, follicle stimulating hormone. These hormones are, like I said, injected in the skin of our stomach. And we will teach you, we have video modules to teach how to do injections. I would say they're so very well tolerated. Most patients are very scared of doing self-injections, but once they've done a few days, they come back for their first return visit, they usually tell me, gosh, that was a piece of cake. They were worried for nothing. Now, during the time that you're doing injections, we'll be doing multiple ultrasound. So, each time we'll be looking at follicles as they get larger and measuring them. And like this period is about 10 to 14 days. And then when the follicles are large enough, we suspect that the eggs inside are mature, then we do the egg retrieval procedure. Okay. Now the egg retrieval procedure is done under anesthesia, sedation and anesthesia, meaning that you're going to get medicine through the IV and you'll be asleep. You're not going to feel anything. It takes about 30 minutes to do. And during the time where the patient's asleep, we will do a vaginal ultrasound. And there's a needle that's attached to the vaginal ultrasound probe that goes through the vaginal wall. And the ovary just happened to be sitting right behind the vaginal wall. And the follicles are filled with fluid. So the needle goes into the follicles. The needle is attached with a tubing to a kind of a syringe or a tube, and through suction. So the fluid comes out and the egg will come with the follicular fluid. The fluid is then collected and the lab our embryologist will go through the fluid under the microscope to isolate all the eggs. Here's a, so basically, hold on one second. Sorry. Hold on. I was not, okay, so anyway, here's a, the needle going through a follicle. And you can see the follicle collapsing with the fluid being aspirated. We cannot see the egg. The egg is microscopic. So we're just looking at follicles. And, amazingly, if the egg is mature and patients are doing injections properly, all the biological process will lead to the egg being released into the fluid, and then we can collect them through this procedure. So if we're freezing eggs, right after the egg retrieval, within a couple of hours, we will go ahead and do the freezing. If we're making embryos, then the eggs are fertilized with sperm fresh, also within a couple hours from the egg retrieval. And then the embryos are cultured in the laboratory for up to a week. And then we can further perform biopsy on the embryos to check for chromosomes, which is another test for screening for health of the embryo. And then typically after the biopsy for chromosomes, then the embryos are frozen. So they're frozen at different stages. They can be frozen at different stages. Now, if we freeze eggs without fertilization, all we're assessing is whether the eggs are mature or not. We can't really assess the quality of the eggs. But later on, when patients come back to use their frozen eggs and those eggs are made into embryos, then they will go through the quality assessment. But of course, at the, patients always ask me, like, what is my success rate? And if I freeze eggs, what's the chance they're going to be healthy? Well, we have a lot of data to be able to give you some educated guess on what proportion of eggs that we harvest is going to be able to make chromosomally normal embryo. But the truth of the matter is, at the time of the egg freezing, we don't really know what the quality is. But we know that age is the best predictor of health. So in order to maximize your chances of making healthy embryos, it's better to try to do this process as early as you can. So anytime you feel like you're ready, we don't want to delay any further, because age and time is probably our biggest liability. So the sooner we can go through this process, the more likely you're going to get healthier eggs. But this is the success rate that we usually try to review with patients. This is a published paper. It's a little bit of they use modeling to try to give some prediction. And you see that the success rates is really different for different age group. So each graph here is the probability. So these lines are probabilities of a live birth. The blue are probability of having one baby. The yellow is probability of having two babies, and the purple is probability of having three babies. And the x-axis is how many eggs that have been frozen. And each graph represents an age category. So 30 to 34 years old, 35 to 37, etc. So you can see that as we get older, for the same number of eggs, you're going to have lower probability of pregnancy. So that's kind of a given. So the sooner you freeze your eggs, the better. Let's take between 30 and 34, for instance. This is the age at the time that the eggs are harvested. If and again, this is a mathematical model that's built from some data, from some clinical data, right? So if a patient freezes 10 eggs, that will give about a 50% probability of having one baby. And the same 10 eggs will have a 15% probability of having two babies, and pretty much unlikely to have three babies. So, so even at a young age, you're going to need more than 10, honestly. So if you want to feel like you have a very good chance of having at least one, I would suggest going in the teens and maybe getting 20 eggs, potentially 2 cycles, etc. And the 20 eggs will give about an 80% probability of having one, and about 50% probability of having two, and a 20% probability of having three. Okay, but if we go to 38 to 40, if we freeze 10 eggs, that's a 40% chance of having one, and only about 5% chance of having two. So there's quite a bit of difference. For most patients, let's say, I think most patients nowadays present for egg freezing somewhere in these age group, between 30 to 37. Um, I would say between 30 to 35, it's very common that one will require more than one cycle to try to achieve, like close to 20 eggs or something like that to give a very high probability of having one live birth. For those younger than 35, oftentimes one cycle could be enough. And anyone 38 and older, I really do encourage patients, as far as they can, as much as they can invest financially, time-wise, et cetera. There's just never going to, you're not going to have too many eggs. So however many cycles you can do, that would be great. And other studies have looked at, what is the safety, the baby outcome for egg freezing. And reassuringly, we don't see any difference in terms of, pregnancy complications and also early, after birth baby outcome in terms of birth weights, APGAR scores, and birth defects, etc. It looks very similar for frozen eggs compared to IVF cycles, fresh eggs. PFC, we've been the 300 babies, most of them probably are from our donor eggs, but we have been doing egg freezing for, at this point, over a decade, maybe 15 plus years, because even when I first started, we were already doing quite a few elective egg freezing cycles. And we have a very robust egg donor, frozen donor egg bank. And we have lots of live born babies from frozen eggs to have seeing our personal experience that the pregnancies are not different, babies are born healthy, not any different from regular IVF cycles. So now this graph is basically what we see when we take the eggs out further into embryos, So either if we're making embryos from fresh eggs from the very beginning, or from frozen eggs, when later on patients come back thaw eggs, fertilize with sperm and make embryos. And then, like I said earlier, the embryos will then go through another test to look at whether the embryos have the correct number of chromosomes. And it's a test for egg quality and embryo quality. And we found, again, this is, another piece of evidence that link age to egg quality. So as we get older, the probability of an embryo being chromosomally normal significantly reduces. Okay, so just highlighting, obviously we can't change our age, but the point of all of this is, if you're already thinking about this, there's really no benefit in delaying, because we can only, our eggs don't get any better. So it's better to try to get the cycle done as soon as possible. So the genetic testing, is a very common part of IVF. So the PGTA is kind of like what I was talking about in the previous slide. We test the embryos to make sure that the chromosomes are normal. And one of the benefits of tested embryo is that it really allows us to do single embryo transfer. And again, we've been doing single embryo transfers for, over a decade. And I think I'm happy to say that even nationwide, people are starting to move towards single embryo transfers. And that it helps patient budget their family better, but also singleton pregnancies are going to be healthier pregnancies with lower miscarriage rates and lower preterm delivery rates. So this is, again, the process, which I already have been discussing. When patients come back to use their frozen eggs, we will then we'll warm the eggs, fertilize the eggs with sperm by injecting every egg with a motile sperm. It's the ICSI process. And then we will offer, and most patients end up doing genetic testing of the embryos. And then we will transfer the embryo back into the uterus for pregnancy. Um, we definitely know and appreciate that patients have lots of options here in the Bay Area for choosing fertility clinics. And I would say the benefit of PFC is that we have been here. We're one of the clinics that have been here for almost 25, 35 years. So and we have been doing vitrification for of eggs since 2006. And this is, and I would say probably at least 30–40% of our patients for, as long as I've been here, are egg freezing patients. So really, we know it like the back of a hand. And the most important aspect of freezing eggs, and the most important, honestly, predictor of success, one is age, is on the patient's end. The other is the lab. It is in the embryologist. It's in the experience that we have in not just freezing eggs, but thawing eggs and making sure that using real life data to know to help improving our process. And we just get better and better over time. So I think I'm gonna, stop right here in terms of the educational part of using the slides. If you have submitted questions, Stephen can go over the questions and we can, I can try to answer them.
Okay, great. Yeah, we do have a couple of questions. Let's see here. The first one that came through, hold on one moment while I pull this up. The first one that came through was, I have a hormonal IUD. Do I need to take this out before freezing my eggs? If so, how long should it be out before freezing my eggs?
Oh, very good question. In fact, for the most part, you don't have to take out the IUD. I usually like to just assess ovarian reserve with the IUD in. If everything looks good, then we can do the cycle even with IUD in place. It does not interfere with stimulation and outcome. Sometimes patients on the IUD don't have their periods, so we may have to be a little bit flexible in terms of planning the cycle in terms of calendar, but outcomes should be very similar.
And then the next question that came through was, besides the genetics and age that can't be changed, for the success of a surgery, how much depends on the surgeon's skills, how much on the protocol chosen, and how much on the equipment? Are there any other key factors too?
Yes, so like I said, actually, the skill of the physician and the lab and the skill of the embryologist really is very critical in predicting success. And then in terms of retrieval skills, I do think that there are very subtle differences from doctor to doctor, but it may not be very obvious, honestly, to patients. And I think we look at PFC, we definitely do a lot of quality control and assessment. We periodically and quarterly review our egg retrieval stats for our physicians to make sure that everyone is on equal levels, right? And then the protocols do, I also think, make a difference because, yes, there is the overarching theme, the overall standard protocol, but everyone is different. So at PFC, our approach is really try to be standardized, but paying attention to individual patients' details so that we can tailor to their own body. And response may be optimized by this approach. And then the lab is just, experience and being able to take care of many egg freezing cycles, and then using the egg, and also having taken care of a lot of egg thaw cycles, and using the knowledge to refine our protocols and SOPs.
Great. Another question just came through. Let's suppose that 20 eggs are collected and frozen. Once a decision is made to use the eggs, what does the time frame look like? Are there wait lists?
Yeah, great question. I think overall, it probably will take maybe 2, 3 months for us to create embryos from frozen eggs. If patients come back, because first we want to assess their current situation, assess the sperm factor. Maybe at that time, now do the expanded carrier screening, the genetic testing, which sometimes can take some time. So, line um, do all the workup. So, and uterine evaluation, etc. So I would give like a month and a half to get those things done. And then we can thaw the eggs, um, fertilization, embryo culture, and biopsy for genetic, for chromosomal abnormalities. I would give that a month to create embryos for egg thaw embryo creation. And then once we have embryos, we can do an embryo transfer. So that already takes us to the third cycle, 3 or 4 cycles. There are no wait lists.
Great. Another question just came through. What is the estimated time between pre-screening and freezing the eggs/embryos?
Yeah, very good question. Egg freezing, I think we can turn patients around in about a month in one cycle. Okay, again, the is workup, which is blood test, ultrasound, insurance authorization or pre-auth, obtaining medication, doing the learning modules, and buying medication. So yeah, give yourself at least a month, and then we can go into cycle. The cycle takes about 2 weeks. What was the other part of the question? Was that it?
Yeah. What was the estimated time between pre-screening and freezing the eggs or embryos?
Oh,
Yeah.
embryos sometimes can take a little bit longer, especially if they want to do additional genetic testing and stuff like that. But even then, it wouldn't be longer than 2 cycles, 2 months.
Okay. Another question that came through. What are the emotional challenges of undergoing a egg freezing cycle, and how can someone prepare for them?
Oh, very good question. Very good question. First of all, I believe everything on the meds, on those hormones, because it definitely make people feel very emotional. You know, I hear all the time patients say they cry at commercials or whatever, so it's true. So anticipate that you will feel very sensitive that, think like you're about to get your period. So there's a little bit of PMS feelings there. I think knowledge and anticipation is the best coping strategy. Knowing that you will be a little bit more emotional and knowing that there's an end to it really quickly. It's only about 2 weeks. We can get through that in 2 weeks. I think that will help a lot of patients. Sometimes the additional layer is that, sometimes if the cycles don't go well, that can add on to additional stress. So we have to remember to take everything with a grain of salt and just, let it happen. And I would try to surround yourself with support, right? And always reach out to your care. Our care team is very good at trying to help patients navigate the emotional challenges, but sometimes patients are a little bit reluctant to share, so feel free to reach out to our team, to your doctor. We're open to, phone consultations anytime free of charge. So utilize the resources that are available.
Great. Another question that just came through was, what about people who are on medication like Zoloft or Adderall?
Yes. I encourage patients to continue that. There's no evidence that suggests that these medications will, interact with stim medications or make eggs worse quality or make you not respond as well. So I definitely encourage everyone who is on, if they're already on some psych medications, to continue, but definitely review what medications you're on with your doctor to make sure that these are okay. For pregnancy, though, then that's a different story. So you definitely want to go over it with your OB to make sure it's safe to take those medications during pregnancy. And the overall theme always is that we prioritize patients feeling stable and in a good place throughout the cycle.
Perfect. Someone just wanted to send out a shout out saying thank you for your information, Dr. Lee.
Oh, thank you.
And another question that came through, and this might actually be one that I can answer. It says, this may not be a question for the group, but are there translators on the staff for non-native English speakers? And yes, we do have staff that speak Mandarin as well as Spanish. And we also have resources where we can actually telephonically link somebody to an appointment so that we can have a translated appointment for them. Did you want to add anything to that, Dr. Lee?
No, perfect.
All right. And then the last question that came through was, where did it go? To have 4 kids, how many embryos should be frozen?
Great question. I would recommend banking 2 to 3 embryos, chromosomally normal embryos for one live birth. So, for 4 kids, gosh, we're gonna need 8 to 12. That's a lot of embryos. So, and depending on the age of the patient, it could be like 2 cycles or 3 cycles. But I think that's achievable. I think you also want to consider, at which age you're starting to freeze and whether you want to consider natural conception as part of your planning.
Okay. And then we got one more question. How long can eggs stay frozen and still be healthy? I'm 24 with 1 ovary and prepping now.
Oh, yeah, great question. Theoretically, the eggs are good forever, just because the vitrification process and the storage they are kept in, minus 200 degrees. So there should not be any biological activity. And with our experience in sperm freezing and embryo freezing, we have viable sperm and embryos after 10 plus years or 15 plus years, and babies have been born. But I do admit that we don't have that long of our data does not reach back that long. So we probably don't have, 15-year-old eggs frozen and then used. Actually, I take that back. I have had recently a patient who delivered from eggs that she froze in like early 2000. So it's possible. So if you're 24, normally I would say maybe wait a little longer, but if you only have 1 ovary, then I think it does make sense to start doing egg freezing now.
The next one is, for 12 embryos, how many a year can I freeze? I believe that might be how many years can you freeze 12 embryos?
Again, you can freeze them for as long as you need to, keep them in storage. And embryos do very, very well.
I might get clarification on that one.
Yeah, okay.
Oh,
you send your questions in an email.
Actually, there's a clarification that came through. For 12 embryos, or how many embryos should I plan to freeze a year to get to 12 embryos?
Oh gosh, I see. Well, that question itself requires the entire consult. So I recommend that you schedule that initial appointment because it really is very different depending on how old you are, what your egg count is, and honestly, how many embryos we can get in the first cycle. So let's just take for an example, age 30, right? I was looking at our data, and for at age 30, on average, we get about 5 chromosomally normal embryos per cycle. Okay, so if you're looking for 12 embryos, you might only need to do 2 or 3 cycles. If you only do 1 cycle a year, that's 2 years or something. Okay, so but each year, each cycle requires one biological, period cycle. And typically we take a rest month after and then do another cycle a month later. So if you want to maximize your time to do IVF in a given year, you can do up to 6 cycles, really. I don't know if I'm answering your question. But flip side is if you're age 40 and you're doing an IVF cycle, on average, we only get one chromosomally normal embryo per cycle at age 40, right? You're going to need 12 cycles to get 12 embryos.
Okay. All right, one more question. And this has to do with age limits. Can you carry a pregnancy at any age? It's probably never thought about this. It is probably harder on the body over time.
Yeah, so really good question. Certainly as women, anyone getting older, when we get into our late 40s, early 50s, I think for most people, they do start to develop some chronic conditions like high blood pressure, high cholesterol, et cetera, which can increase our vascular, like a risk factor for vascular disease. And therefore, it does decrease uterine blood flow. And we do see that implantation rate, pregnancy rates in our late 40s, early 50s is going to be a little bit reduced. But we still see overall patients can successfully carry a pregnancy, but OB risks are higher. So if you're in that age group, talk to your OB, get your annual exam, get tested, get your labs done to make sure you're healthy to carry a pregnancy. We actually do have an age limit, which is 55. Beyond 55, we will not do a transfer. And also, but we also have different age limit for different types of treatments. So if you're interested in that, we can discuss separately.
Okay, great. All right, well, that's concludes the questions that came through. We just want to thank everyone for joining this evening, and we hope that you found the presentation informative and helpful as you navigate your individual journey. We encourage anyone who's joined us tonight to reach out to info@pacificfertility.com to redeem your $99 consultation. That includes initial consultation and ultrasound. And if you have any follow-up questions, you're also welcome to contact our clinic at 415-249-3665. And you can also just send those inquiries to the email at info@pacificfertility.com. We're here to help. On behalf of everyone at Pacific Fertility Center, we just want to say thank you for spending your evening with us, and we wish you a wonderful night.
Take care.
Thank you. Thank you,
you.
everybody.